Stefany, over to you.
Great. Thank you, Dr. Baglik, and thank you, everybody, for having me here. I just wanted to say hi on camera. Unfortunately, I cannot share my screen and be on camera at the same time. So I just wanted to pop on and say hi, and I'm going to go off screen as we're sharing. Let me pull my slides up, and we will get going. All right. Okay, well, thank you, everybody, for the tee up. As I mentioned, I'll be off camera for the duration of this, but I'll come back on during the Q&A. So as Michelle and Dr. Baglik mentioned today, we're going to be talking about looking at data outside of your four walls to advance health equity. Well, and while the focus will be on a health equity, social determinant of health spin, we'll be also talking about how some of this data could actually aid in far more than just health equity, whether that be revenue or reimbursement, conversations and negotiations, or internal process improvements. And I'll talk more about all of that, but really excited today to share that with y'all. So just a quick brief overview of the 45 minutes that we have for the webinar today, followed by our 15-minute Q&A. This is what we intend to get through. So first, I'll just tell you a little bit about me, mostly my background and kind of how we came to be here today. I am going to then go into what I mean when I say outside of your four walls, and we'll go into that in great detail. Then we'll talk about, as I mentioned, some use cases of what you could potentially do with this information and brainstorm a little bit. And finally, we'll wrap up with some real world examples, some free resources and tools that can get you started on your way, as well as some specific data source ideas that could help empower some of the analysis that I'll be talking about today. On the left here, you can see the description that was marketed as far as the content and the summary of the presentation today. I think we covered most of it, but I do want to just say again that we'll be focusing on some real world examples to show how you might start thinking about blending community level data about social determinants of health, because typically we think about social determinants of health at a patient specific level. So I want to explore how we can start to think about blending community level data with about SDOH and community type risk factors or community vulnerabilities with your own internal data sets that you may have access to understand how they impact outcomes, cost, performance, and some other things. So hello, I'm Stefany Goradia. Thank you for the great introduction, Dr. Baglik. I just quickly, if you want to get in touch with me after the meeting, I'm always happy to talk about data questions. You can find me on LinkedIn. If you're interested in data resources, data articles, you can follow on Medium. You can also find me on the website there if you just want to talk about anything else. But at the top, you'll see a little bit about my background. I know we have a lot of clinical leaders today. I'm going to guess, though I haven't seen the attendee list, that many of you are from health systems or hospitals or providers of some sort. I will say I've worked strongly in the payer space as well as state agency space. The use cases that we'll talk about today, I'm going to gear towards more of a provider-centric focus, but do know that if you're in the audience and you're not from a provider or system of some sort, not to fret. The tenets that we'll talk about with some of this data can be applied across pretty much any healthcare stakeholder who's managing a population of people or really just wants to understand what's going on and how they can make an impact. A little bit about my background and experience. I've worked across the entire healthcare ecosystem in some way, shape, or form using data from essentially all of these entities, sometimes alone and sometimes in tandem. And the reason I like to share this is because, we're often so siloed into, our one area or our domain. So if we're in a health system or a provider of some sort, um, that's kind of the lens that we see things through. We look at our data that way. But then we go into our conversations with, our health plan contracts, contracting team. And then they're bringing, to the table different data. And it's kind of the same data, but it's kind of not. And they're looking at it a little bit similarly, but kind of not. And then if we go one step up, if we're talking about like a health plan, like a Medicare or Medicaid plan, maybe, then they're starting to deal with CMS and state regulations. And then CMS is looking at different data, both about the health plan and about, the providers. And it's kind of the same, but it's kind of different. And I could go on and on, start adding in digital health or health technology vendors, our EMRs of the world, or even our remote patient monitoring devices, whatever it may be. The point is, as you can see, there's a lot of data. And while we are able to see kind of what I kind of refer to as within our four walls, so our own data, there's a lot of other people bringing data to the party. And there's even more than what we're showing here. We'll talk about it. But the reason that kind of looking across all of this data is so valuable is because we're going to start to paint a really holistic picture. And I think that's a really big paradigm shift to what we've been doing in the past with data, which has largely been, taking what we have in our own systems and what we can procure that's pretty close to us and deriving insights from it. And today we're really going to talk about just expanding that whole model and expanding that whole mindset beyond just our four walls, which we'll talk again in great detail about. I like to show this slide because it's so complex, all the different players in the ecosystem. Just a little bit about my company and how we're sort of uniquely qualified and why we were invited here today to talk specifically about this issue. We're a technology company. We deal with nothing but data, as Michelle and Dr. Baglig mentioned. I head up the healthcare vertical of that, and I've devoted my entire career to health and healthcare. We bring data scientists, AI practitioners, engineers, software developers. So we've really worked entrenched in a lot of this data. We've done a lot in social determinants of health, health equity, urban health, and urban resiliency. This wheel shows a little bit of our capabilities. I'm not going to go into great detail about each of them, but at the end of the day, it's a really unique and very innovative place to be because combining all of these disciplines all around data with the expertise in healthcare, it's really allowed us to create a powerful knowledge base and look at some of this data in new ways. That's what I'm excited to share about today. We are headquartered in New Mexico, downtown Albuquerque. We're growing fast. I'm proud to share that we made the Inc. 500 last year due to revenue growth. And the reason I like to share that is because if you've ever been to New Mexico, you know that people are often very excited and sometimes surprised to see a company like ours in New Mexico. New Mexico is a very unique state with its own unique challenges, as we all do have. But our state is wrought with health inequity and very unique and challenging socioeconomic situations and scenarios. And in fact, after COVID, New Mexico, nearly half of our state, between 40 and 50% as of the last month that I just looked at, is on Medicaid covered, and I think estimates range between 80 and 90% of the births in New Mexico are actually covered by Medicaid. So not only are we dealing with some challenges in the state, health and healthcare and how we manage health of our people is very, very challenging here. And that's why I have such a keen interest and a keen devotion to it. So from all that experience, that's our mission, is really to advance health equity and improve healthcare through data. And we live that every day. So without further ado, let's get down to it. Let's talk about the future. The future is data. And as you can tell, if you couldn't tell already, the future is already upon us. And so I'm excited to share my thoughts on that. All right. Well, this is not a COVID presentation, and I'm sure you all have sat through many, many, many COVID presentations. But what I will tell you about COVID and data and how it pertains to what we're talking about today is that COVID caused what I think will be a real paradigm shock to the system. Many of you are probably already experiencing that with the rapid shift to virtual care, remote care, digital health technologies, hospitals without walls, things like that. So it's no surprise there that COVID caused a shift to our healthcare delivery, philosophy, if you will. And I think it may be, it may be the kickstart that we might have needed to start implementing some of these things and thinking about reimagining, care delivery workflows very seriously. For me, from the data side, because I'm not a caregiver, I'm not a clinical person at all, I will say that COVID has also shocked and rocked our world, just here in data, specifically healthcare data. And part of the reason, and I won't read through these bullets, but I'll touch on the key points for them. So, the first point, like I mentioned, fundamentally changing how we're delivering care. But more importantly, as I mentioned, for me, from a data perspective, COVID really and very quickly exposed all of the gaps that we have in the healthcare system, in our current data systems, exposed the gaps and frankly, the inadequacies in our ability to share data, share meaningful data, timely data, and in some cases, even accurate data. When COVID came, everyone scrambled. It was a valiant effort. Everyone had to pull through, and a lot of things got kludged together. But it really highlighted as more and more people were asking questions like, well, how many cases, did we have, and how many hospitalizations were due to COVID, and what's the mortality rate, and just all the reporting, and then the cross-referencing against vaccination records. Again, more data. Trying to get things out, equitably, trying to reach again more data. Trying to share patient history and background on the fly, more data exchange. It just really, and at the end of the day, everyone still kind of felt like they were behind on the numbers or didn't really know what was going to happen because frankly, what came down to a lot of either a lack of data or inability to move quickly enough on it, to not only understand the current state of the state, but also to try to predict and model and look a little bit into the future. And of course, during the pandemic, everybody was so desperate to do so, rightly so. So, for us in the data world, it really exposed that, shed a light on it. And again, I do think COVID will be a cause for a major paradigm shift in the data world, simply because of that, even if we're looking beyond healthcare delivery. So, leading into the third point there, while health equity, we've been talking about health equity for a while. We've certainly been talking about social determinants of health for quite a while before that. Um, I really do think that COVID also exposed and exacerbated some major inequities in care. And that was brought forth to light by looking at some of this data. So, COVID kind of a triple whammy. It's going to change our care delivery. It exposed gaps in how we do data now, and it also exacerbated some of those social determinant of health risk factors and how they impact and again exacerbate some of these health inequities that we've been talking about. So it was just a real big shift. And we'll talk about how all that comes together. But and then finally, just a little bit more philosophically, um, as I mentioned, across the entire healthcare ecosystem, there's no shortage of players, vendors, partnerships, and collabs. So really more data is being generated today than ever before. And since we're moving more towards this digital technology, digital transformation, there's going to be a ton more data even on top of that. And all of this to say that if we continue to only look at the data that we have internal access to, even if we're a large system, multi-hospital system, what have you, if we're only still looking at the data that we have to see internally, we're missing a huge portion of what's going on outside or the rest of the picture. And that's what we'll talk about today. What's going on outside of our four walls, or what some others may consider external determinants of health, or maybe more narrowly social determinants of health, that's actually quite a large piece of the picture that, I've read different estimates, but generally I've seen somewhere between 80 or even 90% of outcomes are somehow either contributed to or driven by all of these external factors, factors that may not even be controllable within our four walls and how we deliver care. That's why it's so pertinent right now to start expanding again beyond what we can see in our own data to some of these outside data sets, which I'll talk a little bit more about that in context. But you can see an example of some of the types of data or some of the types of data sources that I'll be talking about in the background on this slide. And I do believe we'll be sharing this slide out, so no need to scramble for screenshots and things, but happy to share it out as well if we don't. So, as you can kind of imagine, as I've alluded to, what do I mean when I say within your four walls? And I want to think a little bit more broadly than just, one facility or one building, one four walls, so to speak. I kind of always say the proverbial four walls. Even if you're a large healthcare system, multi-hospitals, multi-specialty, whatnot, you're still fairly going to be limited and constrained by what you can see within your organization. So you can kind of think about that. The data within your organization that you can see. And it's robust data. We can do a lot with it. So, I think over time, we've looked at quality measures. You have access as clinical leaders to, of course, your EMR, and there's clinical data. There's all kinds of reporting on it. There's all kinds of internal performance improvement type measure, KPI type measure information. You may have access inside of your four walls or inside of your organization or inside of your technology stack to some patient specific data. You may have some patient specific social determinant of health factors if it's logged in the EMR record or the notes, or if you have a special SDOH tool or assessment, things like that. You, of course, have some encounter history if that encounter occurred within your four walls or within your system. You might have, if you're lucky, and depending on like kind of who you are and what kind of arrangements you're in, you may even have some access to your patient's broader claims or utilization data that occurs at other providers other than yourself. Again, depending on your situation, if you're in a value-based care arrangement or some sort of capitated pop health type of arrangement. So that's kind of a maybe. And then, of course, medical history and referral info. We may have that if we've captured it or if we have systems in place. But this is certainly not exhaustive, this list, but I think I just wanted to illustrate what sorts of things that we're all traditionally kind of looking at within our organization and the systems that we have to support it, largely, again, within our four walls. And now I want to talk about what I mean when I say outside of your four walls. So here's just an example of some of many, many, many types of data that live outside of your four walls that can be used for some of these initiatives that we talked about for more robust analysis. And we'll go into some of these. But again, this list is certainly not all exhaustive. As you saw, a number of data sources on one of the previous slides that I showed. But I'll just start in the upper left here and kind of go down the list. So fitness trackers and biometrics, that's kind of a specific name for what you may have also heard referred to as IoT, or the Internet of Things. It could also include medical devices, either in room or at home. But this bullet basically just refers to any kind of medical device, program, system, or otherwise that has information about your patients um, that may or may not have been collected by your one of your own systems, and that has very valuable and sometimes very real-time information. There's a big push towards digital health. Again, IoT is a common term in the tech world because everyone's trying to figure out how to grab that data from the Fitbits and pull it into either our EMR and then do some analysis on it or use it to be able to drive, real-time action. So that's one example. Going down the list here to the second on the left, the location and distance to resources, those are typically map-based or resource directory-based data. We may have some, we may know where, our nearest homeless shelters are, or, behavioral health provider up the street, whatnot. We may even have a provider directory across, all of the, providers in the state who accept Medicaid or whatnot. But this can really be expanded upon to go even to the point of, let's map all of the pharmacies in the area and how far is an individual patient or a neighborhood of patients, really how far are they from their nearest pharmacy? How far are they from their nearest grocery store? How far are they from the nearest church or park? All kinds of different stuff. Anything location or address based or geospatially based can be compared to some of your own data to see, like, when we send our patients home or when they're out there in their communities and their neighborhoods, like, what does that really look like in context? We'll talk a little bit more about that. Moving down the list, we have disease and risk factor prevalence. Depending if you're a public health background or not. I kind of look at this like prevalence and incidence across your region. So again, if we're just looking at data that we have within our four walls, we know what the disease case mix or chronic condition type numbers that we may have based on the patients that we treat. We know in the region those values. But what we don't always know is within our neighborhood, what's the overall disease prevalence or rate of certain types of conditions, or that for patients who are maybe not even being treated by us, so we don't have visibility into where are the neighborhoods and the pockets that have the highest, behavioral health conditions, acute behavioral health conditions, and struggle with that, or what is the diabetes rate in a neighborhood, and it can be very, very different from the next neighborhood over. And so not only does this kind of speak to looking globally, but really when I say looking at these prevalences and what's going on in the community, I'm really talking about getting down to even like a neighborhood or a very specific, sometimes even a city block level. And it's really going to help us to understand those differences and drive the decisions that we make as we either discharge patients there or treat patients who live in these areas and whatnot. And again, we'll talk through some use cases. Moving down to the bottom, health plan data, that is a extremely robust set of data. Claims data, that's typically claims data. If you don't already have that, that can tell us a lot about where else the patient went, for what, did they follow up like we asked them to with their specialist? Do they have some diagnosed conditions that we didn't even know about because we ourselves have never treated them for that? Um, I could go on about claims data for days and days and days, but that's just some examples. From the claims data and kind of blending it with some of our own internal clinical data on the bottom right here, that comes some population health and some quality data. Now, when we're as providers looking at quality data or thinking about quality measures, I guess, a lot of the times we're thinking about what did we influence in our four walls, such as our hospital-acquired conditions and our CAUTIs and our CLABSIs and things like that. What's our readmission rate? As you can see, these are all things that kind of occur within our four walls. Well, then our health plan payer comes in and says, well, you're treating this diabetic patient. They belong to you, so to speak, and they haven't had their eye exam yet. And that's where we start having some breakdown because the payers again are looking at some data um, from their claims, and they're looking at different quality gaps, and it's not something that you have within your system. And so these can come together for really powerful program initiatives and collaborations to make sure that all of our diabetics get eye exams, so on and so forth. To the right, at the bottom, community vulnerabilities and social determinants. Again, I like to talk at the community level because a lot of times, we anecdotally know what our patients are going through on a personal level. We see them a lot. They come to our EDs. We capture, person, lives alone or doesn't have a car or what have you in the record. But what I don't know is when I'm discharging somebody to a specific neighborhood that's right next to some kind of a power plant or something that, some kind of a plant or manufacturing plant that has a lot of pollution, or is just in a generally poor air quality area, right by a highway. There's really specific things that when we talk about social determinants can very well be at the community level. Crime rate, family history of violence. There's all kinds in the region, socioeconomics, veteran status, all kinds of stuff that can really be looked at a community level. And again, we'll drill into that one pretty deeply. Moving up the ladder here, one of my favorite, external benchmark data. You may use some benchmarking data if you use tools like MIDAS or if you look on CMS Hospital Compare, things like that. There's some quote benchmark data out there that kind of answers the question of how are you doing compared to your peers. A lot of times that's only going to be showing very specific quality measures, like some of the ones we talked about, hacks and readmissions and things like that. But there is a wealth of benchmark data out there, whether you're a payer, a provider, state agency, what have you. There's just a lot of data out there that could be used to kind of see, again, the state of the state and how you're doing or where you fare or what your peers are dealing with compared to you. And we'll talk about how that information arms you for better conversations and program initiatives. And then finally, one of my personal platforms, I guess, Health Information Exchange. I don't know the mix of who's from where on this call here today. I can tell you in New Mexico, we haven't had a um, as robust or very strong health information exchange as we would like. But for those of you not familiar with the concept, health information exchange is essentially a centralized repository where providers will contribute clinical information, clinical data, clinical record for patients, goes all into this central health information exchange. And then if the patient goes to a different provider within the state or whatever, they can look you up in the HIE and they can see your clinical record from the hospital across the street. Normally the hospital and that provider would never talk to each other, or they'd exchange, record by record, fax or whatever. HIE really seeks to get like a longitudinal patient record so that providers across the entire ecosystem can look together off of that system and get important information like the most recent CT scan and the results and lab results and when they last had the lab test and things like that. So not only does that reduce redundancy, but it also increases patient experience and it just gets everyone on the same page. Again, it's kind of a lofty philosophy with the HIE, but it's just another example of data that might exist out there outside of your four walls that could help to inform clinical care or program initiatives and so many other things. Now, I talk a lot about this data and I kind of talked about them separately, all as separate little buckets. But what I want to tell you is that merging all of this data together is when the power really comes to life. So all of these data and data sets that we talked about, they all can be looked at individually, and typically they are. So I may go to the census website, I may download some social determinants of health, and I might be looking at by zip code. And then I come over to my EMR reporting, and then I might pull some, patient registry of my patients, and then I'm kind of maybe trying to crosswalk, zip code to where they live and look at this other, the real power is going to come when we can just easily merge all of this internal and external data together and harmonize it, which is much easier said than done, and sounds a lot more peaceful too. And then overlay it and basically analyze it together in tandem with one another. And that's when our new trends come up. That's when our new correlations are revealed. That's when we can start exploring our neighborhoods and our patient populations and even our state or region in deep context. And what information would doing something like that reveal? Well, there's a lot. I've rattled off quite a few use cases and there's quite a few many more. But really, I kind of tried to narrow them down to three major buckets that I typically see, though this is certainly not exhaustive. So first, on the left, community risk factors. I mentioned already some of the differences, from a data perspective of a patient-specific risk factor or a social determinant of health factor to a community type risk factor. Some factors may actually present either at a patient level or at a community level. For instance, veteran status. Me as a person, I can have a certain veteran status, but I may live in a community that has a much different proportion or status of veteran status. I may not be a veteran, but I may live in an area that's 90% veterans. Same could go for like smoking and, socioeconomic type things. So, some of those risk factors cross over, but I like to focus again on some of those specific community level ones. So this helps us to understand what community level risk factors or vulnerabilities are impacting the neighborhoods and the people that we serve. What's important to them? What language do they speak primarily? What do we need to be aware of when we're going in? And really, at the end of the day, how can we better serve them? The middle one here, a little bit more lofty, I guess, but extremely relevant, are some of those deeper systemic barriers. That'll lead up to some of those real major health equity or really more appropriately health inequity factors that we see. So the way I think about these systemic barriers and how this data helps to reveal those to me is I can go in there and I can see the trends. I can see my readmission rate, over time. But what I can't see is what are some of the major root cause systemic risk factors that could be highly correlated with a high readmission rate. I can look in my own data and say they were discharged without their meds, or we didn't follow up, or they got an infection or whatever. But, I don't know, again, I'll go back to my air quality example. I don't know that I discharged them, and they had COPD or something, and I discharged them to an area that has, a really high pollen count this time of year, or what have you. I don't know that, I'm discharging them to a an area that's got no grocery store for miles and miles and miles, and it's very important that they eat a certain type of a diet, or something like that. So, those are, again, just some use cases of many. This goes much, much deeper and much, much wider. This starts getting into some of those health equity and equitable distribution of care and access. One other example I'll share that's a little less patient specific is, we've been doing a lot of work recently with telehealth, and so everyone's excited about telehealth. They want patients to use it. Well, some people want their patients to use it and are excited. We thought when COVID came that telehealth would be a great way to reach our patients and Medicaid clients and health plan members, or whatever it may be, that were living in rural communities that couldn't make the trek in. Well, then when we started to overlay that with where broadband access is and where cell phone signal is or is not, the picture quickly became that telehealth actually favors those in metro areas, um, just from a connectivity perspective. On top of which, we saw that that telehealth was further focused in more affluent neighborhoods that probably tended to have more smartphones and technological literacy, and um, even English as a first language. I mean, there's all kinds of stuff that, as we start peeling this onion, we can really start to see some of these. We may not say correlation. We say correlation doesn't imply causation, but we can start teasing out some of these stories that serve as directional pointers that allow us to start thinking about things in different ways. Finally, on the right, equitable care, equitable access to care and services. We know that, for instance, anecdotally, we know there's provider shortages. But again, as I mentioned, what are the specific neighborhoods down to a block level? Because even if you're looking at a zip code, and especially if you're looking at a county level, that can vary one street over. With no pharmacies, no grocery stores, no transportation, no specialty clinics, no, whatever it may be. Who lives here? How do we reach out to them, and how do we help them based on what their needs are, based on what we can see their health needs are from our internal data, and now with our external data as well. I'm going to show you a quick example in action. This is it's a social determinant of health visualization tool that we built in combination, or in collaboration rather, with Humana. It's called Zoom In. It's a public free tool. There's only 275 communities loaded up into the tool. You can find that on the Humana website, but I'm just going to show a video. But this is an example of a tool that Humana wanted to launch to look at some of these things that I'm talking about, and they specifically launched it to help providers or care coordinators to look up an address of a patient or a member, and identify some of the factors in their region or their community that were of importance, and help guide those conversations. So I'll just kick off this video and kind of talk through it. So the interface, it's geospatial in nature, but you can, in theory here, the provider or whoever it may be will enter the address. It'll pull it up. We like to use San Antonio because there's lots of little pockets. But we use some machine learning to kind of create a social determinant of health risk score for some key major risks like physical activity, inactivity, food insecurity, social isolation. Moving to the map view, we can start to explore and overlay different types of data in the fashion I mentioned. So now I'm going to show all the areas that have high prevalence of people who are over age 65. And the hot pink shows me the areas that have a higher rate of people over 65. And then if I layer in, also now show me some of these other social determinant of health factors, and they're just scrolling through the list there. The map starts to zoom in and carve out very specific areas in the across the city that meet all of this combination of factors: over 65, where the mental health providers, number of unhealthy days, and so on and so forth. This is a quick and simple flyover, but it just kind of shows how we can start to put that information together to really hone in and zoom in, if you will, on specific areas that may have opportunity for us to go in there and think and reimagine care delivery. So I want to move a little bit to what you can do potentially with this information. And again, this is not exhaustive, so you can see how this is just majorly impactful, has a lot of opportunity and a lot of really a lot of different areas that concepts like this can be used. But here again, kind of some of the three major buckets that we tend to see. Starting on the left, something that I've worked a lot in, as mentioned in my introduction, were like performance improvements and things. Something we might call a targeted initiative or targeted improvement or a performance improvement, what have you. But it's really, at the end of the day, it's like, where does the data say that we should focus our resources? Like, we know anecdotally that our patients are XYZ or suffer from, ABC, but at the end of the day, our resources are limited. We need to pick the ones that will move the needle the most in the areas that we need it to be moved the most, whether that's from a monetary perspective or quality measure perspective or what have you. So what does the data really say? And how does it point me to where I need to really focus? And this is where we can start saying, okay, this neighborhood or these patients who live here with these conditions and are impacted by this or whatnot. So we can start to really just strategically pinpoint with precision where should we focus some of these improvement efforts. And then even further, what kind of intervention or what kind of initiative does make sense based on what the data says? So it almost points us to, okay, well, they're really far from a grocery store. That seems to be one of the major contributors. So we can consider things like food pharmacy or HelloFresh deliveries or food deliveries or what have you. I don't know. This is where we get to have fun and reimagine how we deliver care. But at the end of the day, it's what kind of interventions are going to make a measurable impact versus what we may have to do now and feel somewhat our hands are tied because we have to either throw darts or we're making decisions based on anecdotes, what have you. In the middle here, one that you may or may not touch on in your role, but it's becoming unfortunately more and more part of the conversation. So contracting and funding. As we talk about value-based care, which surprisingly, COVID now I think has taken the spotlight over value-based care buzzword. But as we start talking about some of these population health type arrangements, value-based care arrangements, contracting for specific quality measures, all of that's going to be tied to our reimbursement and maybe change how we're even reimbursed across the entire system. We can start using this kind of information that we've talked about today to drive the conversation with the payers rather than payers coming to you and saying, hey, we need to improve XYZ quality measure, here you go, we want a contract for it. Well, you can say, well, wait a minute, I'm looking at all this data and I see that people in our area are actually suffering from this and they have barriers to this, and the money you're the reimbursement schedule you're proposing is maybe not going to be enough. Could we consider also covering a food benefit or a transportation benefit? Like, it really allows you to have a voice back and present your case with data, or even come to them and say, hey, we noticed that in this region there's this, that, and the other, and we can help. Here's what we want to do, and here's how we want to fund it. Those are just some examples. Of course, case mix index and the risk of your patients and the acuity of your patients always comes into play when we're talking about contract negotiations and reimbursement. So these kind of information can even support grants, unique benefit coverage, all kinds of stuff. And then finally on the right there, addressing health equity, all of this at the end of the day leads up to that. All roads lead to this concept of health equity or inequity. And really at the end of the day, we need to identify where these people are falling through the cracks, why, and how they're impacted, typically disproportionately impacted by new programs, policies, procedures, technologies, such as the telehealth example that I gave. We have about 2-3 minutes left, so I just want to slip through these last couple of slides quickly. Again, we'll send this out. These are just some simple examples, some starter sources to consider. even these data sets that I have up here, CMS, census, CDC, you'll quickly realize that a lot of this data is really challenging to pull down and to deal with and to analyze, and that's pervasive. That's been one of the main reasons that we have not, really, as an industry, really gone this way quickly. Even though it seems kind of like almost like a no-brainer sometimes, because of course we need to look at this kind of information, but the challenges, the data challenges, are just so hard. So I got a list here. You can start poking around. Data.gov is an amazing resource. CMS puts out a ton of data about, you know, down to a CPT level, down to a provider level, like how much of the Medicare population did provider A serve, and how much did CMS Medicare pay them versus provider B. You could be provider B. All kinds of data out there, all kinds of sources. We've talked about some really high level data sets and data ways to use that data. This could go very high level. I like to say you can zoom out to like even a regional view. But depending on what kind of data you have, you can zoom all the way into a patient address, and you can map your patients out on the map and see where they are and what communities they fall in. That's one way you can take that data further, even further, as you get further along your path. And then one thing I haven't even mentioned is predictive modeling and AI. There's a ton of new methodologies coming into play that's going to start consuming a lot of this information, using it to make like a composite risk score to understand some of these root causes. And most importantly, what I'm most excited about is we can use this data to say, what are these trends going to look like in 2 years, 5 years, 10 years? Because we're designing some strategy around it. So we need to kind of predict out how these social determinants of health might impact. There's a couple examples of some even more advanced data. One example that we use at RS21, we have anonymized cell phone location data. So we can, it's all anonymized, but we can see, for instance, like how often do people in a certain region go to fast food, to bars? How far do they have to travel in drive time to a grocery store? Not as the crow flies. Where are the areas with real social isolation? Not just averages and numbers at a high level. There's another resource on here. It's covid.rs21.io. We have a number of different census type data loaded up, and you can explore communities by the census tract in ways that I explained. There's some disease prevalence and things like that, and an urban health risk score, just as a way to dip your toe and to start looking at some of this information that we talked about today. That link will be in the slides. So that's all I have. I could go on and on and on, but I think Michelle wants to make sure we have at least 15 minutes for questions. So I'm going to put my contact information up here. I'm very active on LinkedIn and encourage you to reach out. I love talking about this stuff. I'm really passionate about it. The data, though it's not easy, in some ways is the easiest part of what we've talked about, and the hardest part kind of falls on you all as caregivers and program managers now figuring out what we do with the information. So the data provides some pointers and some first starts and some data-driven evidence, but where we go from here is still TBD, and love to talk with you all.